Oh, hi there. My name is Serge Mekanovic. I'm a GP at our medical home in Oxenford. Why am I here today? We have a very important subject to talk about. I simply want to share my experience with you. So hopefully you will be able to help your patients improve their life, save their relationship, prolong their life. I have been involved in substance misuse for well over 17 years. I used to be a GP with special interest in alcohol, and I was running detoxification units in the United Kingdom and also completed specialist degrees and diplomas in alcohol addiction. This hopefully makes me competent to talk to you on this subject. What I'm going to try and do is now share my screen with you and my presentation, and we'll go from there. Right, so today we're going to talk about motivational interviewing. What is motivational interviewing? Motivational interviewing, or shortly MI, is a counseling approach used to motivate a person to change destructive behaviors. This technique is often used for addiction, as lack of motivation to quit can be one of the greatest barriers for individuals struggling with addiction, even in spite of health issues, financial, social, and legal consequences. The thought behind motivational interviewing is that all individuals dealing with addiction are at least partially aware of the negative consequences of substance misuse and addiction. Each individual is also currently in a certain stage of readiness when it comes to changing their behavior. The MI therapist facilitates the process of getting ready to change by overcoming ambivalence or fear of change, increasing the patient's own motivation. MI is a complex skill. It's like you want to play a musical instrument. You watch other plays and you attend a 2-day course, but that's highly unlikely to make you a competent musician. You can learn about a complex skill by reading about it, watching demonstration, taking a class, watching me, but the mastery takes practice, practice, practice. You have to have a skill of good listening, and you have to remember that MI is not for everyone. It is only one tool that can be helpful. And finally, helping people learn MI is a privilege, and I appreciate those who allow me to assist them in learning it. Many addicted individuals lack motivation to change for 3 main reasons. Firstly, they don't think that their substance abuse problem is as serious as it really is. Secondly, they don't want to give up the positive sensation associated with the substance they're using. And lastly, they fear the consequences of ceasing substance use, including withdrawal symptoms and cravings. Many addicted people actually go through stages of grief after giving up the drug of their choice. Motivational interviewing has been shown to be effective, not only in patients who have voluntarily sought out treatment, but also in those who have been given required addiction treatment as part of legal settlement or pressured into it by their loved ones. There are 7 key points to MI that should be maintained across variations in MI technique. Those are motivation. It comes from a patient, not from outside sources. The patient is responsible for resolving ambivalence, not the counselor. Ambivalence cannot be resolved through direct persuasion. The counselor quietly elicits information from the client. The counselor guides the client in recognizing and resolving ambivalence. Readiness to change is a fluctuating result of interpersonal interactions, not a trait. The patient-counselor relationship should resemble a partnership. And as you can see, there are various stages of change. Those are labeled as pre-contemplation, contemplation, preparation, action, and maintenance. It always is important to remember the counselor is not an expert. Patient has responsibility for change. Strategies are more persuasive than coercive, more supportive than argumentative. and counselor seeks to create a positive atmosphere conducive to change. Everybody is motivated by something. Remember that. You just need to find that motivation in the patient in front of you. Why do people change? What prevents people from changing? There are key points about change. It's a difficult process. It's not comfortable. It's obviously easier to stay where you are, to stay the same. We normally tend to go back to the old ways. Change requires creativity. Change requires open mind. Change has emotional and cognitive components. Change happens over time. The process is as important as the result. Often there is a difference between what someone knows they should do and the readiness to do it. Greatest chance to impact change is pairing it to the specific stage of change. And I keep talking about this, that it's really important to remember all over again and repeat the same thing all over again, that counselor is a partner. You cannot conduct a consultation within motivational interviewing with authoritative way. You are there to explore and support your patient in front of you. You can't be confrontational. You can't have a coercive approach. You have to resist the writing reflex. You need to understand the patient's own motivations. You need to listen with empathy. You need to empower your patient. All responsibility for change is patient's own. You need to respect their autonomy. They have the freedom to accept or decline the counsel you're providing them. And it has to be patient-centered. They need to figure out, they, not you, what to do, and not you telling them what is best for them. Spirit of motivational interview is a fairly simple process that can be completed in a small number of sessions. The typical steps are as follows: engaging, talking to the patient about issues, concerns, and hopes, and establishing a trusting relationship. Focusing, narrowing the conversation to the topic of patterns and habits the patient desires to change. Evoking, eliciting patient motivation for change by increasing the sense of the importance of change, confidence that change can occur, and readiness for change. Planning, developing a set of practical steps the patient can use to implement the desired change. As you can see, what I said so far, we are trying initially to resolve the ambivalence, emphasizing the reason for change rather than advising them, showing our understanding, exploring pros and cons, and connecting with their patient values. And as the Albert Einstein once said, insanity is doing the same thing over and over again and expecting a different result. This is an important slide and important cycle of change. As I already said, MI is a patient-centered model of counseling, meaning that the focus is on figuring out what patient wants, not what the counselor thinks is best for them. This requires high level of empathy, reflective listening, and ability to form a strong bond with the patient in a short period of time. The main point of MI is overcoming the internal battle over whether one really wants to quit or not. Even though there are clearly many reasons to stop abusing drugs or alcohol and get serious treatment for an addiction, to an addicted individual, there are also many reasons not to do so. Patients may go back and forth many times, feeling motivated to quit after encountering health or legal consequences of drug abuse or conversation with a loved one, but losing the motivation the next morning. MI is clearly there to lay out the pros and cons of quitting based on what patient feels is important. Once patients overcome denial and come to their own conclusions about pros and cons of their addiction, their desire to change, what the change looks like, and how they want to implement the change, it becomes a lot easier process for the change to take place. Patients don't feel forced to give up something they love. Instead, they're pursuing a life of change that they themselves have chosen. This method of counseling appears to be especially effective for alcohol addiction, likely due to the fact that it's easier to be ambivalent about the use of legal substances due to a greater social acceptance than there is about the use of illicit drugs. According to an analysis of studies published in the Journal of Clinical Psychology, MI is up to 20% more effective than other treatment methods for alcohol addiction. The success of MI in treating substance addiction has resulted in it being tried for other types of addiction, mental illness, behavioral issues. This includes gambling addiction, eating disorders, low self-esteem, parenting practices, and increasing motivation for positive behaviors like healthy eating and exercise. The stages of change model encompasses many concepts from previously developed models. The health belief model, the locus of control model, and behavioral models fit together well within this framework. When we are talking about, now we're going to talk about different stages of change, starting with pre-contemplation. During the pre-contemplation stage, patients do not consider change. They may not believe that their behavior is a problem or that it will negatively affect them. That's a health belief model. Or they may be resigned to their unhealthy behavior because of previous failed efforts and no longer believe that they have control. That's an external locus of control. What can you do? You need to commend the client for coming to treatment, establish a report, ask permission to address the topic of change, and build trust. Elicit, listen to, acknowledge the aspects of the problem behavior the client enjoys. These are some examples. I'm not going to talk much about them, but there are so many opportunities that you will encounter in dealing with patients while they're coming to see you, when you can try and use MI to address the change. During the contemplation stage, patients are ambivalent about changing. Giving up and enjoy behavior causes them to feel a sense of loss despite the perceived gain. During this stage, patients assess barriers, time, expense, hassle, fear. I know I need doc, but as well as the benefit of change. During the contemplation stage, patients struggle with ambivalence, weighing the pros and cons of their current behavior and the benefit of barriers to change. That's a health belief model. Your goals here are to decrease ambivalence and strengthen intention to change. This is also a good way you can give them a chance to write down what could be the positive aspects or the negative aspects of change they're trying to achieve. In preparation stage, patients prepare to make a specific change. They may experiment with small changes as their determination to change increases. For example, let's say sampling a low-fat foods may be an experimentation with or move towards greater dietary modification. Switching to a different brand of cigarettes or decreasing their drinking of alcohol signals that they have decided a change is required. In the action stage, this is the one that most physicians are eager to see their patients reach. Many failed New Year's resolutions provide evidence that if the prior stages have been glossed over, action itself is not enough. Any action taken by patients should be praised because it demonstrates the desire for lifestyle change. Maintenance and relapse. Maintenance and relapse prevention involves incorporating the new behavior over the long haul. Discouragement over occasional slips may hold the change process and result in a patient giving up. However, most patients find themselves recycling through the stages of change several times before the change can be truly established. Cognitive behavioral models of change, example, focusing on coping skills or environmental manipulation and a 12-step program that you probably all know about fits well with this preparation, action, and maintenance stage. Matching intervention to motivation, the key to whatever or not MI will be effective, often depends on a counselor. MI is a difficult treatment method to master, as the counselor needs to be able to build trusting relationship with many different types of people. So just about anyone can become addicted to a substance. Substantial patience and understanding are necessary. Yet the process is also designed to go quickly due to the fact that many individuals are unable to pay much for the therapy, or maybe in the midst of the legal battles related to drug use. However, a counselor who can overcome those challenges may be able to help those who have been unsuccessful with other treatment methods. Basic methods that you use in MI are open questions, affirmations, reflective listening, and summarizing what you have discussed. The basic is called OAS. You're asking open-ended questions. You tend to let the patient does most of the talking. That gives you the opportunity to discover what patient cares most about. You're making affirmations. You're giving compliments or statements of appreciation and understanding. That helps you to build a rapport and support the patient during this process of change. You're using reflections. That's really important. You are rephrasing the statement that the patient made, encouraging them to talk even more. And at the end, you are trying to summarizing just to make sure that you both understand each other. Those are the simple examples what you can ask in the open-ended questions. It's highly and often forgotten, the affirmations. You need to think about the patient. You need to think about their behavior, their struggles, the way they're thinking, the way they're feeling. And you need to give it to them. You need to appreciate them. You need to find the positives in them. You need to be a reflective listener. They need to feel that they're getting the support and understanding and they're heard. And you have to summarize in the end. You have to be selective, because there's probably going to be a lot they have talked about, but I just need to get the key aspects across and the summary with invitation. Use the change directions or ask key questions. And I'm going to try and give you an example of a consultation you can have with a patient that would give an idea how this consultation takes place. I will give you one example of talking to a client where I would be using OAS to establish rapport and address the client drinking through reflective listening and asking open questions. So Tom is coming to see me today. I'll start by saying, "Hi Tom, how can I help you today?" And the Tom says, "My wife thinks I drink too much. She says that's why we argue all the time. She also thinks that my drinking is ruining my health." So Tom, your wife has some concerns about your drinking. She thinks that your drinking is interfering with your relationship and harming your health. "Yeah," says Tom, "she worries a lot." So Tom, your wife worries a lot about drinking. What concerns you about it? And Tom says, "I'm not sure I'm concerned about it at all, but I do wonder sometimes if I'm drinking too much." So Tom, you're wondering about the drinking? Too much for? That's an open question that invites Tom to complete the sentence. And Tom says, "For my own good, I guess. I mean, it's not like it's really serious, but sometimes when I wake up in the morning, I feel really awful
and I can't think straight most of the morning. So, Tom, it messes up your thinking, your concentration. Yeah, says Tom, and sometimes I have trouble remembering things. So, Tom, do you wonder if these problems are related to drinking too much? And Tom says, well, I know it is sometimes. So, Tom, you're certain that sometimes drinking too much hurts you? Tell me, what is it like to lose concentration and have trouble remembering? And Tom says, it's kind of scary. I'm way too young to have trouble with my memory. And now that I think about it, that's what usually causes the arguments with my wife. She'll ask me to pick up something from the store, and when I forget to stop on my way home from work, she starts yelling at me. So, Tom, you're scared that drinking is starting to have some negative effects on what's important to you, like your ability to think clearly and good communication with your wife. Yeah, says Tom, but I think I'm not an alcoholic or anything. So, Tom, you don't think you are that bad off, but you do wonder if maybe you are overdoing it and hurting yourself and your relationship with your wife. And Tom says, yeah, you know, Tom, it takes courage to come to talk to a stranger about something that's scary to talk about. What do you think? And Tom says, I never thought of it like that. I guess it is important to figure out what to do about my drinking. So, Tom, let's take a minute to review where we are today. Your wife is concerned about how much you drink. You have been having trouble concentrating and remembering things and are wondering it has to do with how much you're drinking. You're now thinking that you need to figure out what to do about the drinking. Did I miss anything? So, as you can hear from my consultation with Tom, I was using affirmation, reflection, open-ended questions, and most importantly, in the end, summarizing our consultation, giving something to Tom to think about when he gets home.
So, what we are trying to do with eliciting change or talk, we're trying to push the ambivalence envelope, decisional balance between change and the status quo. We need to talk about disadvantages of the status quo, advantages of change, optimism about the change, and intention to change. When you're speaking to a patient, you need to try and figure out and try and see from their body language or what they're talking about, desire, ability, reason, need, commitment. You need to focus on motivating your clients. It is a counseling skill that needs training, and more you do this, more you practice, the better you're gonna get at this. Once your patient gets motivation to change, then he will be able to apply his own natural skills to accomplish that change. And don't forget about the motivational cycle, where your patient is going through pre-contemplation, contemplation, but then you are there to encourage him and make planning stages, actioning, and trying to maintain it, try to prevent them going back to where they were before. However, this process might take some time. So don't be discouraged if they try and fail. They'll try again, they'll fail again, but you just need to really explain to them the cycle of change and encourage them to go through it, stage through stage through stage. There are different patients, and you need to remember, you need to try and resist their temptation. They might be arguing with you, they will be interrupting you, they will be denying, they will be unwilling to change, they will be pessimistic, they will be ignoring what you're telling them, there'll be no answer, they will not be responding if you're talking. You're trying to resist this. This is the way the patients are going through the change, and you need to get through this. Never meet resistance heads on, never argue, never criticize. Never talk to them about the negative consequences. Never pursue them with logic or evidence. It does not work. They need to be the ones to initiate the change, and you're just there to motivate them. You need to roll with the resistance. Difficult patients have difficult strategies, but you just need to roll with that resistance, emphasize the personal choice, and keep telling them that they're in control. And that's what I wanted to tell you. It is a beautiful subject, and I hope you have now confidence or maybe some idea what motivational interviewing stands for. And I hope you all the best on your journey, and I wish you and your patients all the best in future.